second. Hi everybody, today we're going to talk about being a preceptor in the PACU. The first part about this presentation is just reviewing the orientation process, and then it kind of finishes up with some tips and tricks of being a preceptor in the PACU. So the first part here is the orientation process, the schedule. So we do week 1 and 2 is typically outpatients. Week 3 to 4.5 is Fanny. The reason I say 4.5 is we got some recommendations from people that had been through the orientation process that they didn't need 2 complete weeks at Fanny. So we kind of do about a week and a half at Fanny. Then we go to the inpatients for a couple weeks, and then we finish up with peds, and then that usually leaves a couple days where we can kind of loop back to any areas where the new hire was feeling uncomfortable and needed a little bit more support. So, of course, we adjust this to every person. If someone has pediatric experience and feels very comfortable with peds, then in a week and a half they might be done their peds. But if someone comes in with little experience and is looking for more practice, then they might get like 2.5 weeks in peds. So having the little bit shorter time at Fanny kind of allows for a little buffer room in the end. So I just want to talk about the binders that that I give out to everybody. They should get 2 different binders, a small one and then the very large one. The very large one, which we should all be familiar with, is the ASPAN Standards and Guidelines, the competency for new hires. I have mapped out on their schedule what chapters they should read each week that they're on orientation, and it kind of mimics where they are in their process. So take a look at their schedule, their printed out schedule, to see what readings they should be doing. When there's downtime, encourage them to do some readings. At the end of each chapter, there are questions that I am going to have them, kind of like quizzes, questions, they can fill out. And so I'm really hoping that we can have people do some readings to kind of back up what we're doing in the clinical environment. The second binder is kind of I tell them to bring this to work every single day. So it starts off with the PACU protocol. So I leave this stapled and kind of hanging out because I want them to bring this to the bedside every single day when especially in the beginning when they're learning our process. The PACU protocol was written by a previous educator who took all of our standards, all of our ASPAN standards, and put it into a nice packet here that lays out exactly what we should kind of be doing as PACU nurses. So just to give you an example, the first part is prior to the admission to PACU, we're going to ensure that the area is prepared for the patient admission. So it kind of just gives focus for the new hire, like what the heck they should be doing for their entire stint of while the patient is in PACU. I would encourage the preceptors to take a look at this and really have the new nurse follow these, obviously within exceptions of patient condition changes or whatnot, but it's a really good tool that I will pass out to everybody. So that's in the first part of the binder. Then as you go through the binder, the first page is just numbers of different resources that they would possibly need. Then it does, there's a checklist here of the PACU orientation day 1. So day 1 is with me. So how it usually lasts, depending on the new hire, like 6 hours, 4 to 6 hours, I would say, depending on how, if we get really tired with the information, then we might pause and do some of it the next day. But generally speaking, so we do a unit tour. I make sure that they have access to PRISM, OR Manager, Teletracking, and Pyxis, and Chronos. And not only do I make sure that they have access, we also review all these programs to make sure that they have seen it at least once, how they kind of work. We go to security, where we deal with their badges and making sure that they have access if they were on call or if they need access to the locker room. We review the orientation process. I review the ASPAN standards. We do evaluations. So every single new nurse gets 3 types of evaluations. At the midway point of their orientation, there's a PACU progress report. This just kind of gives us a sense of what they've seen and where we might need to go with their orientation. So the second section here says circle the following surgeries that you've seen: FATS, carotid, fempop, gastric sleeve. If there were any surgeries out there that you guys felt was really important for someone to see, please let me know and I can add them to this list here. So our goal would be by the end of their orientation that they've seen these procedures. And if they haven't seen these procedures, at least had a good conversation with either myself or you guys about what the recovery looks like for them. So that's the midway progress report. Then they fill out one in the end that kind of does an overall evaluation of our orientation, the scheduling, support from me, the managers, how their day at the OR went, readiness to be independent, what procedures that they have seen in the end, what different skills that they have participated in. So have they had an experience with an A-line? Have they done an epidural? Have they had a patient that was a chronic pain patient? Do they have a patient that was unable to void and needs to prior to discharge? And then we ask for their feedback. And then they rate preceptors. So they go through and say, and sometimes they feel comfortable with me sharing the information back to the preceptor, and then sometimes I've heard they're like, well, I'd rather not have you share it with them. And so, but they do evaluate you guys. And then the third evaluation, you guys fill out on the new hire. And it is broken into different categories: critical thinking, clinical knowledge, technical skills, communication, management of responsibilities, patient rights, and safety. And it's all based on 1 to 5, and it breaks it down into a bunch of different topics. And we find this one really important. We've used this in the past if there have been challenges during an orientation to really focus on where we need to go with things. So I would take a look at this at the beginning of their orientation. They get exposed to this so they know what the expectations are, and then you guys fill that out in the end. So back to talking about what we do on day 1. So we talk about those evaluations. I do a 30-day checklist. That's a hospital requirement. It's just reviews infection prevention policies here. We talk about the structure of our hospital, who our director is, goes over a whole bunch of organizational structures, job description, customer service needs, dress code requirements, attendance, timekeeping schedules, personal security stuff, safety manual, fire and safety, utilities and equipment, hazard communication, infection control. So I do the 30-day checklist with them on that first day. Then I review with them the call book, holidays, vacation book, conferences. I do the PACU protocol. We go into depth about that. I'm also adding in this time asban.org. I think having a better knowledge of what the resources are on asban.org. So we're going to review that. We'll actually take a look at the webpage together. Types of anesthesia. I do an entire presentation in the last like half hour, 45 minutes about different types of anesthesia, where we would see them, what our nursing considerations are. I do a PowerPoint on malignant hypothermia. We talk about dantrolene. I actually have some outdated dantrolene that we mix up. We show them where the cart is over in OR, the OR area, internal control area. We do Philips monitor. I do documentation. We talk about paper charting. We talk about emergencies here versus at the Fanny and what your responsibility is as the bedside nurse. We review the charge nurse role and the PACU nurse role and what those expectations are. And then I talk about safe medication in the PACU and how we are different than other areas. So that's a lot on day 1, and we kind of feel it all out, but we go through that whole process. Other parts of this binder is there's PowerPoints that I've printed out to kind of go along with, so the types of anesthesia, the malignant hypothermia. The expectations of the nurse and the charge nurse. One thing that came out of one of my new hires this past year was they felt very confused of the anesthesia hierarchy. So I did the anesthesia hierarchy, and then I also did the surgical tree, so who we would call at what point for what needs for surgery, and then also for anesthesia, how it kind of works. Like, people would be very confused, like, I need to call the primary versus the charge, like, how does that all play out? So I kind of drew it out on a map in hopes that that would solidify things for people coming into our organization. Then there's a skills section. So this is your classic competency checklists. The tasks on them have kind of been broken down week to week. I know this seems like a silly request, but I guess it's a joint commission requirement that we used to, or I have seen in the past, people initial the top line and then just do a line down saying that they covered all of those things. The joint commission is saying that that's not valid, that we actually need to physically initial and date every single line that we cover with them. And I find it really important because at the last week, if there are topics that have not been covered at the bedside, then I go back through with the new nurse the last week I'm working with them and say, oh, it looks like you never talked about whatever, and then I'll actually review it with them at that point so they actually get it signed off. So that's the skills section. Validation, so this is just like some stuff about continuous bladder irrigation. And then the competency checks off, which would be great if you guys could fill out. So this was not the bladder irrigation, sorry. So like art line is in here. So if you see them actually do an art line, then go through an initial and make sure that all the key points were touched upon. So there's art line. This is more art line stuff. Bladder scanner. This one frequently comes back to me empty, so I know we do it. So if you see them actually witness them doing bladder scan, if you could just make sure the points were touched upon and sign an initial. Chest tube competency. Epidural, which I do pumps with them. If they come from an outside hospital and aren't familiar with Alaris pumps and epidural pumps, I will do that, but I might not necessarily sign this off because I would like them to actually do it in the clinical setting. PCAs, and that's the last part of that section. Then policies, I made a list of policies that are pertinent to our area, so I encourage them, maybe once a week just go up and look up some of these policies and read them through, especially if they're coming from an outside organization where things were different somewhere else. Definitely to go through and read the policies. I don't actually print off the policies, just with policies changing so much and being updated. I'd rather have them go to the internet where they can get the most updated policies. So there's a list of them here, but I don't print them off. And then the last part here is just my weekly modules that I'm going to talk about next, I believe. So that's the orientation binders. So the orientation process, so this is just day one. Everything I kind of just mentioned that I talk about with them on the first day. If there are topics that would be helpful for them, for new hires to hear on the first day, please share with me those topics so I can kind of include them in different parts of their orientation. This is the example of the PACU protocol. I will make sure that I get a copy to everybody also prior to all the preceptors to have prior to new nurses coming in. So my weekly learning modules, so how I set it up is, so I work with them day one, then they kind of go out and do outpatients the first week. Then week two, I meet with them. It says week one, but really it's actually week two, week one of learning modules, but week two out on orientation. I do airway, so how I've set up most of the learning modules is that there's a PowerPoint, then there's a hand-on portion of it, and then there's like a case scenario studies / question quiz, however you want to look at it, at the end, that I collect all of those and we have some really good conversations. My apologies that I have found I've set an hour limit on these and I find that they sometimes run like an hour and a half, so my apologies if they're not right back to you right away. So airway, pain management. I actually take a trip over to the Fanny and do Fanny emergencies and Fanny stuff with them over there. Vascular patients, that includes carotid, FemPops, AAAs, and TAVIs. Pediatric patients, continuous bladder irrigations, and then the final weeks we just wrap up with evaluations. In addition to doing the learning modules each week, of course I check in to make sure everything's going okay. That's when we make adjustments to the orientation schedule, what they need to see, what they haven't seen, and so on. So the weekly readings, so you'll see it on their schedule, so encourage them to, if there's some downtime, to sit down and do the readings. I know it's a lot and it's after working 8-hour day, you don't want to sit down and do some readings, but even if it's a 15-minute chunk and they just do part of a chapter, then they're at least hearing it from a different avenue and not just seeing it at the bedside. The more they can hear it, the better it is. And then there's quizzes at the end of the chapters that need to be completed and returned to me. So the new hire progress. So if there are any issues at any point, any red flags, anything that just doesn't feel right, gut instinct, whatever it is, we absolutely want to hear about it as soon as possible. So one great way to kind of track things with documentation is to email myself, Karen, Bethany, and also page us right away and let us know, especially if it's a safety concern or if they, from one of these, from the evaluations, if they're not following one of, critical thinking or something just doesn't seem right, we want to hear about it. The sooner we hear about it, the more likely the new hire is going to be able to succeed with that challenge and kind of move on from it. So definitely let us know as soon as possible. So the paperwork, I'm sorry that there is paperwork. The really important thing for me to collect is that competency skills checklist that I was talking about in the small binder under the skills tab. If you have 5-10 minutes at the end of every shift, just go through and sign because it will be fresh in your mind what has just been reviewed. So sign initial things. I do need to get this back. If I could get it back a few days prior to them being completed, then anything that hasn't been touched upon, I can kind of meet with the nurse and just review the final things. So to give them the fair chance once they're out on their own. Yep, and then that initialing. So just to give, I got some of these last few slides from, I went to preceptor workshop recently or in the last 6 months, and I found some of these things really helpful. So types of learner. So there's definitely different types of learner, and while this is a really hands-on environment, if we can kind of accommodate, if we find someone that is, a visual learner, can we give them pictures? Are there things I can be doing, giving you guys some tools that would make it more beneficial for them? So we have the sensing learners, so minimize surprises, give the details, establish a method with them. The intuitive learner, who likes an overview, let them innovate, watch the details. You have a visual learner who likes to demonstrate, take notes, use body language carefully. And a verbal learner, they have the RN repeat back. They like written instructions. They use words and tones carefully. Other types of learners, so active learner, they're hands-on. I think a good chunk of who we probably see in nursing are hands-on learners, but I've definitely had people come through that are, do really well by reading something and, or from the case scenarios. And that's why I try to make the weekly learning modules different, so maybe it would touch on different people's personalities and types of learning. So the active learner loves to teach, great preceptors, part of the group. Reflective learner, they like time. One-on-ones is best, stop and review, wait 7 seconds after asking a question. So I'm going to talk about that in a second. Sequential learner, do things in a specific order, can't skip steps, simple to complex. Global learner, they'll ask, what is in it for me? They might skip details. Destination is important. So teach back method. After providing teaching, ask the new learner to explain the material you have just covered. Based on their response, you may need to reteach material or information. So where I find this really important is when, say you went and did A-lines and you went through all the steps of doing zeroing the A-line and they maybe demonstrated, maybe didn't, but you don't have the physical time at that moment to reteach, then let me know. Because if you let me know, then I, in one of our weekly learning modules, can get out my art line trainer and we can do it, because some people learn better not at the pressure of the patient. So, if you're finding this on certain topics, then just let me know and we can reinforce it outside of the bedside. Safe word, I love this one. So at the beginning of your orientation, it would be great if you and your new hire could establish a safe word. Don't care what it is at all, but a safe word is great is if when you're at the bedside and the nurse is about to perform an unsafe task, such as giving IV medications without scrubbing the hub, then you would use your safe word and without embarrassing the new hire in front of patients or families, then they kind of know, like, that means stop. So if you were to say purple, that means they need to stop in that moment and reassess what they're doing and kind of look at the situation and either have, try it differently or, wait for your instruction. But I really like the safe word. So the 7-second rule, and I'm really trying hard this was a good learning opportunity for me. So the evidence shows if you ask a question and wait 7 seconds, that the person will most likely answer. So which that meaning it takes up to 7 seconds for people to assess a question and come up with an answer. So wait 7 seconds after asking the new learner a question. It gives them the opportunity to answer. And I've really found, since I have learned this, I have really found that to be true and interesting. Like, really wait that 7-second period and people most often will come up with an answer. Did you know we have to hear something 6 to 9 times before we commit it to memory? So repeat, and repeat again. Something to think about. I find this very interesting too. 55% of how we communicate is with our body language. 38% is the tone of voice, and 7% is the actual content of what we say. So just be very self-aware of how we're looking and how the preceptor is, or the new nurse is, and this is just kind of a definition of a mentor. They model, they nurture, they teach, they organize, they respond, you inspire, you network, and you set goals. So 8 tasks to help facilitate learning. Discuss goals and expectations with the learner. I think this is huge. I think if we at the beginning of every shift, we could just spend 2 minutes just being like, what are we going to achieve today? We're going to step it up and take 2 outpatients versus 1 outpatient, because we've been doing 1 outpatients for the last 4 shifts and you've really done well. Today we're going to work on 2 outpatients, and I'm going to step in and do this if this happens and really set the expectation, and then at the end of the day reassess. Were you able to achieve that 2 patients, and really giving them the support and almost a push at times to like move on to the next step. Create a supportive learning environment, show enthusiasm, which I think a lot of you already do because we would not have picked you if you didn't. Motivate the learner, be excited for them. Help the learner identify what is important in the situation. I think that's really huge, really point out what things can be. Don't worry about that, and let's really focus on this. Use questions to stimulate memory and previous learning. Huge. Just ask questions. Be curious. If they do something one way, just say, I'm really curious why you did it that way. I would not have thought to do it that way. And it might get to the same answer and achieve the same goal, but in a totally different way. And so what I always loved about precepting people is I learned new things all the time. Like, wow, I could do something that way, and I never knew that, but we still get to the same goal at the end. Where did I leave off here? Supervise, active practice, and hands-on experience. Generalize to the broader learning process. Play the what-if game. You have 2 seconds. Hey, what if our last patient all of a sudden went apneic and stopped breathing? What would you have done? And then kind of do that on the fly, and that kind of triggers them to think more critically. Provide ongoing feedback and promote self-assessment. Talk out loud, play the conversation in your head out loud so they can begin to learn how an experienced nurse thinks. To them, it looks like you leapt from A to D, and they don't know what you thought through B and C in your head. Isn't that true? We all day long know what our end goal is. We need to get these patients safely either discharged or to the floor. But in their mind, they're thinking of A, B, C, and D. So feedback for the new learner. You can do it nicely. There are kind of some verbiage that can be done nicely and still facilitate good learning. So what are your thoughts about your interaction with? What was your rationale for suggesting blah, blah, blah to this patient? What was the most challenging experience that you had today? Great question. To us, they might have seemed like their day was cake. They were awesome. They did fantastic. But maybe they felt like they had a challenge throughout the day that we didn't see, and see what it is and see if we can kind of make it better the next day. Can you describe one activity or patient interaction that you performed today that made you feel proud? Always ending on a positive note because we want this to be a great experience. So in a nutshell, be patient. The knowledge that you possess was not gained overnight. New nurses often feel overwhelmed by the amount of material that is thrown at them. Make sure the orientee understands the basics before teaching them and the details of the subject. Remember, they are novices and cannot complete tasks or work at the rate you do after years of experience. Be a role model, be a positive professional and practice model. Discuss your behaviors and why you make certain decisions. Lead by being a caring example. Set expectations. Meet together at the beginning of the orientation to discuss expectations and preferences. Continuously evaluate. Give kind and consistent feedback. Be mindful of your verbal and nonverbal communication. Outline a plan for improvement. And be excited. Show that you enjoy learning and precepting. Remember, you are influencing the future of nursing. And most importantly, thank you. I know we've had a lot of turnover in the last year, and we've had a lot of people precepting over and over again, and every time everyone does a fantastic job, and so I really want to say thank you for all your hard work. And come grab me at any time for any questions or concerns.